I'm excited to have a very special guest here talking about CBD and fibromyalgia. Now, many of you who are watching or listening to this podcast or YouTube video living with fibromyalgia or chronic pain syndromes have either tried CBD or cannabis themselves for fibromyalgia or other chronic pain, or at least thought about it. And there's a lot of buzz around it, but the science always hasn't kept up. Now, your study that we're talking about today is one of the first rigorous trials to really put CBD to test for fibromyalgia. So, welcome to the podcast. Before we dive in, and I was just going to ask, could you say your name and your background and what kind of work you do and how you got interested in the world of fibromyalgia?
Yes, well, my name is Marianne Rasmussen, and I'm a Norwegian citizen living in Copenhagen, Denmark. I'm a registered nurse. It's my background. And then I was able to do a master's degree in public health. And after that, I've done a PhD in health science. And then I did research on fibromyalgia in my PhD. I have worked with fibromyalgia since 2007. And I find it's a very interesting patient group to work with. It's very rewarding to work with this group. I have worked within rehabilitation, multidisciplinary rehabilitation programs, a 2-week program that we have been running in a hospital in Copenhagen. So I did that for many years. And then I was able to do my PhD in 2013. And since then, I have been working with research within fibromyalgia.
And was there anything special that drew you to the world of fibromyalgia?
No, I think it was a little bit by coincidence that I got a job working with patient education for this patient group. And I had been away from working as a nurse for many years because we lived abroad with my husband, and coming back to it, it was a good start for me to work with education rather than being in the clinical ward, working day and night and weekends. So that was a little bit by coincidence, but I really early on found out that this was a very interesting group to work with, and I wanted to make it the focus on my work and research after that.
Well, thank you so much for your interest. And it's often a very stigmatized condition to live with for so many people. What made you and your team want to do this study that we'll be talking about in the first place?
Yeah, as I said, I've been working with non-pharmacological interventions for this group. And we had been testing that in my PhD, and we found that we couldn't really help on the pain outcomes with a 2-week rehabilitation course. We could help them with their functional ability, actually. They did improve on their functional ability, but the way they saw their pain in the questionnaires were not changed. So I thought, we need to look for something else. And then I was in the Danish Medicines Agency when we was looking at recommendations for this patient group. And I thought we'll have to look at cannabis and medical cannabis because that would be very relevant. And it was very hyped at that time in Copenhagen. And then I discovered that there was no evidence on the subject, so we were not able to make any recommendations. So I thought, oh my goodness, somebody has to investigate this. So I guess we did try to investigate the non-pharmacological interventions. I thought we should move on to looking at pharmacological intervention and then CBD, because I knew already that many patients were using it on their own and so on. And it was unsafe, I thought, and also very expensive for them. So yeah, so we decided to investigate it and put up this study.
You mentioned looking at the evidence before you did the trial and seeing there wasn't a lot of evidence, and I guess looking at this, there have been studies looking at some CBD or cannabis in general for chronic pain syndromes, but looking at it, felt it was lacking. Can you give maybe a kind of a summary of what studies have been done and what were the big gaps and maybe quality of those studies?
Yeah, we did not find any studies who have investigated pure CBD for fibromyalgia. It was often combinations of THC and CBD, and for other conditions like neuropathic pain or lower back pain or anything, lots of other conditions. So I couldn't find any randomized trial that had been with a big amount of patients and long follow-up times for this. There was non-existent. The studies we found were often very small, maybe 8 to 10 participants, very short follow-up times, and they were sometimes included in reviews and meta-analysis, but the quality was really low, so they couldn't we couldn't use them to make a clinical recommendation. And because I learned how good should a study be to be able to include it in the recommendations. There were none. So nobody had really investigated fibromyalgia and CBD only,
Yeah.
if any.
It sounds like in the US, is in the last, I don't know, 5-10 years of my career, CBD has been touted. We can get it often in places that are over the counter. Many states, the cannabis is still not legal, at least in the United States, and wherever people are listening in the world, it may vary. But many have tried CBD anecdotally. Often it's like, oh, I've heard patients say, oh, maybe it helped my back or my neck or knee. But in the world of medicine, we like to, and the gold standard is that randomized controlled trial. And many people with fibromyalgia are often desperate, willing to try this, maybe have tried this. Now you got a chance to put it to the test. And maybe starting with the big picture, what were the most important findings from your study, and what surprised you and your team most when you saw the results?
We were very surprised when we saw the results. To sum it up, we found no effect of CBD 50 milligrams daily for 6 months on pain, unfortunately. There was no efficacy, no effect, no benefits. And it was the same for quality of life, sleep, and functional ability. These were our key outcomes in the study. Pain was the primary outcome. When you make a rigorous trial, you have to do it by the book, and we did blinded analysis. So when we got the results back from the statistician, we were very excited to see that there was actually a statistically significant group difference favoring one of the groups. At that time, the groups were called X and Y. We were excited because we thought if it has no effect, it's probably no difference between groups. But here we had actually different on pain and quality of life. We had to write a blinded abstract. We also had a vote within the research group whether we thought X was CBD group or Y was CBD group, and that group X was the one that had the best effect on pain and life quality. When we were unblinded, we were very surprised to see that group X actually was the placebo group. The placebo group had a significant improvement on pain and quality of life, and the active group did not have this improvement. So it was very surprising.
Yeah, that's interesting. I'm glad I asked that question. You don't always see it when I'm reading the paper, or at least I maybe didn't pick that up, that the group was blinded even to this. You don't know. Can you walk through the recruitment of patients, the type of patients, mentioning fibromyalgia, and what were the details of this? And for those who may not be familiar, like what is a randomized controlled trial and how did you carry that out? Because it sounds like it was a very carefully planned, rigorous.
Yes. We have a database in Denmark of patients who have been through our non-pharmacological intervention that I mentioned before. Everyone that has been through that since 2007 when we started it, they are included in a database, and it's called the Danish Fibromyalgia Register, DANFIB, and my study is called CANFIB. Anyways, so we could recruit from this group. We had more than 1,000 people in the group that had allowed us to contact them in case there was a study that they could participate in. So we invited them through some electronic system, and they could get back to us if they wanted to. These were all patients with fibromyalgia who had been treated in a hospital setting. So they were like maybe people that were quite, they had it in a high degree, fibromyalgia. They had very low functional ability and were struggling. So this was from a hospital setting. We did not do advertising and have anybody come in. They were already diagnosed and they had been through rehabilitation earlier. A randomized controlled trial is that you gather a lot of people. We needed 200 and we were able to include exactly 200. And then you make a draw or you make it random so that you divide them into two groups randomly. assign them to groups. And this is we do this to make sure that the groups are alike, that they are comparable on all other kinds of outcomes than the pain. And we were able to do that. We got exactly 100 patients in each group, and they were comparable. We also did something called stratification. So we made sure that the age was taken care of also, because we had a big age gap. The youngest ones were like 17, 18, and it was up to 75. So we made sure that it was evenly distributed on age, sex. We had a few men, actually, I think only 10 out of the 200 were men, and they were also evenly distributed in the two groups. And it also level of pain. We measure pain on a scale from 0 to 10, where they can put their mark on how they experience their pain at the moment of answering the questionnaire. And we had a cutoff over and or under 7 on this scale, was also evenly distributed in the two groups. So the two groups were even. That was taken care of by the randomization. I hope this makes sense.
Yeah. And then part of this is moving into treatment. You have, and I'm reading through the study, the medication, the CBD, and the placebo were made to look identical, smell identically, so that nobody could have any hint.
Exactly. We gave the medication in tablet form. Sometimes you can also use it in oils or other kind of forms. So then it will be difficult to mask or to make them even on taste and smell. So a white little tablet pill they were exactly the same, no difference in smell or taste. And this was to also ensure the blinding for us as the health professionals and for the patients.
And then they started treatment, and they were treated for how long?
Yeah, they started the treatment on the day they were randomized, assigned into group, either for the treatment group, the CBD group, or the placebo group. And we started with 10 milligrams per day, and then we scaled up from every third day, took 10 milligrams more. So in the end, they had 50 milligram. After about 2 weeks, they were up in the dosage, and they took 2 in the morning and 1 in the middle of the day and 2 in the evening of the 10 milligram tablets to kind of divide it all over the day. If they couldn't tolerate 50 milligrams, they were allowed to go down to a lesser dose, but then they had to stay on that dose for the rest of the trial. And it was a 6-month trial period.
Yeah. So looking at this, you have this result here coming back that placebo actually came back as slightly more powerful than actually the CBD. Were there any differences in side effects between the two?
So it's probably because of the side effects that we didn't see such a good effect in the CBD group. So when we looked at the side effects, they were also evenly distributed. There was actually quite a lot of side effects also in the placebo group, which was a little bit strange, but I can't really explain that. And I think we might have made a mistake. We asked, have you had any side effects every time? We saw the patient quite often. I think it came about 10 times during this period, because we wanted to look after them. And this might have been a little bit of a mistake, because we did actually, as you can imagine, get quite a big placebo effect in this study. But they all got side effects, but they were also evenly distributed between groups. I think we had a little bit more influenza in the cannabis group. This was also during COVID, so we had a lot of people getting.
Yeah.
This is not a side effect. It's like an event. We have to register every event, whether it's related to the medication or not. But otherwise, it was the same. And the most common was the nausea, diarrhea, dryness of mouth, and headaches. And that was evenly distributed. So that can't explain the difference between groups.
You chose plant-derived CBD rather than synthetic. Why that choice, and how might that matter?
Yeah, in Denmark, it was already by a politician put in place that it was allowed for doctors to prescribe plant-derived or organic CBD to patients. So this was already in place in 18, and we started our study in 19 or planning for it. Therefore, we found that that was most relevant to go on with what was actually allowed in the country. And it was also, we found a patient preference. They rather have an organic remedy than a synthetic one. We know that synthetic could be have better purity and be more accurate. But our compound that was organic was tested by the Danish Medical Agency and found to be consistent with every rule. So we thought it was fine. But yeah, so the reason was the political scheme already in place and a patient preference.
The dose you chose was 50 milligrams a day. Some might argue that maybe a higher dose might be needed because of CBD's poor absorption. Can you comment on that?
Yeah, we didn't find any dose response studies to help us decide on the dosage. So that was made by clinical advice, recommendations by expert advice. And you can argue we should maybe have tried a higher dosage. But we know about another study looking at pain for knee osteoarthritis. They had 600 milligrams of CBD and tried that out for that kind of pain. And they found no effect either, but quite a lot of side effects. And therefore, we chose to follow the recommendations for fibromyalgia for 50 milligrams to be sure.
And that was that an open labeled study?
Yes,
Randomized.
mass trial. Yes, that was about,
Yeah.
and they got.
So what do you and your team make about this strong placebo effect, and especially in patients with fibromyalgia?
Yeah, we know that just being part of a study can also contribute to placebo effect because you get, we looked after the patient really well. I have to also tell you that we asked all the patients if they thought that they got the active medicine, and they all did. They thought that they got the active ingredient, although they knew that only half of the patients would get it. So they were very optimistic about getting the real thing. And then this patient group is, as you said yourself, marginalized and stigmatized, and often haven't maybe had very good experience with health professionals before. And when we take them in a study, they are assessed in all kinds of ways. They see lots of health professionals, the same ones maybe over time. Then we give them a lot of time and attention and care. And this has definitely contributed to the placebo effect. I kind of knew it along the way. This wasn't good. But on the other hand, they were very happy to be in the study. And we seem to have helped them. So I think that tells another story in a way.
Yeah, well, tell me more about what story that might be telling.
I just remember I was so disappointed when we got the result and we did the unblinding and that the favor was in placebo. So I actually spoke to some doctors because I met some just that weekend, and they said, but this is an interesting result because this means that what this maybe we need to do is give these people more time and talk to them and take them seriously and assess them and yeah, all of those things that we did apart from giving them the medication help, but also it probably also helped that they all thought they got the medication.
Yeah, I guess it talks about, when you look at often invisible illnesses, for me, a thought when I read through this study was many of the disenfranchised, stigmatized group will often be stuck with what we call alternative or functional medicine, where we don't have strong evidence, but you have actually a caring professional who may spend a lot more time, but then your conclusions may be, oh, you have mold toxicity, or you have some metal toxin in your body, and we'll give you this special concoction or homeopathic medicine, which in a sense is a placebo, and the therapeutic alliance with somebody who cares, who listens. Now, the conclusions, talking not so much about nociplastic pain or centralized pain and the impact that's complex by our social relationships, the environment, our spiritual connections, activity, stress, food, all of those play a role. But having somebody who cares, who listens, who validates. Now, I would argue the conclusion's often drawn, but at least there's somebody offering something about this.
It's important, definitely. That's what we can learn from this. I actually asked one of the male patients who was really struggling. He had been a sports person and was used to doing a lot of activity and wasn't able to do it anymore. And he said he didn't have any effect of the drug at all the time. And said in the end, I'm sorry we weren't able to help you in this study because he all the time said he did not have an effect on his pain. But then he said, but I'm much better now than I started in the study. So I was surprised to hear that. So even though he told me it didn't help to his pain, he still felt that he had improved somehow by being in the study.
Yeah, and I guess it's somebody getting attention, being cared for. I think for many clinicians who are listening, hopefully, to this podcast, whether they're newly minted clinicians, whether nurses, PAs, medical doctors, that often when we have a patient like this on the schedule, we want to, in a sense, inherently see them less and bounce them to other specialists when actually spending more time, taking time and coaching, it goes a long way.
Definitely does, yeah. But it's unfortunately the case that that's not often what happens. As you say, many doctors, they don't really know what to do about it. So it's difficult, but it's so rewarding when you spend time. It is for sure.
Yeah, and that's part of why I decided to write a book and do a podcast and bringing this over into the YouTube channel. So I have listeners throughout the world, people from Norway and Europe and Australia, I think every continent listening because they often aren't getting this. The most common question I have is, do you know anybody in Brisbane, Australia who does what you do? And I'm like, I don't know a lot of people who do this, but I'm hoping more doctors will be willing to a good evidence-based approach, comprehensive, bringing this in because it's often the most rewarding patient to help when they've been discounted and given up hope. The details of the study, did you use you talked about functional scores. Did you use the fibromyalgia impact questionnaire revised scoring as part of that along with what were the things that you actually measured in the study?
I used the FIC revised for my primary outcome, the pain, and
Yes.
we use it for energy. We use it for other outcomes that are not actually in the first paper. They will come in the next. We haven't looked at that yet, but we did use it for the primary outcome. That's true, and we use it for different school also that we haven't published yet.
Yeah. I'm just looking through my notes here. One of the things that you mentioned, and I will be doing an upcoming episode on this, is that how men are often underdiagnosed. There's a study out of Pittsburgh where they had people do a plot diagram of where their pain was in a pain clinic, and yet very few were diagnosed. Like there was a huge underdiagnosis based on their data interpretation that there was many people who were actually underdiagnosed with fibromyalgia, and how men are probably closer to 1-to-1 ratio, if not 2-to-1 ratio, but often in these studies, it might be 95% women getting diagnosed. And similar to what your study was this because about 95% of the fibromyalgia patients in your database are women? Or is it just the women wanted to do the study, or does it reflect the prevalence?
It reflects the prevalence. It reflects the patient that we have in the clinic. Maybe it's a little bit more men. Maybe it's 90% and 10. In the study, it was a little bit less men. But yeah, it does reflect, and definitely, I also agree. I'm sure there are many more men out there having fibromyalgia and being underdiagnosed because it's looked at as a women's disease, but it's not. It's also men that have it, definitely. So we wish there'd be more men. We're trying to do some studies on men only as well, because when we have the rehabilitation programs, we do the men separate, so they are in groups together. Because we found that it's quite rewarding for them. They're not used to meeting other men with the same conditions. Twice a year, I think we have groups of men only. So we're doing some research on them, some policy research with them to compare.
And what can you comment just more broadly on, and I don't know where if cannabis with THC, general cannabis, is legal in Denmark or not, but what do you know about the studies in general for cannabis for both fibromyalgia or just generally chronic pain, and kind of looking at the type of trial you did, which was very rigorous, randomized controlled trial showing placebo actually was better. Can you comment on just the broader studies about cannabis, not just CBD, but cannabis in general for chronic pain syndromes?
Yeah, as I said before, we did not find the rigorous studies on THC or a mix of CBD, THC. We didn't. So I don't think there is a lot out there. I haven't checked what's on the way right now. So there was few studies, and I've heard recently some newer studies that have actually found they've been on CBD and they have found the same as I have, that there hasn't been an effect on the randomized controlled trials.
So a lot of people out there, maybe if they're listening now and they're using CBD and they think it might be helping them,
Yeah. That
what would you say to them?
if they think that is helping them, for sure.
But should I stay on it? They're wondering, well, should I spend this amount of money? I'm not sure where the cost is and everybody where they're buying it, and it can vary. But if you have a patient in front of you that just comes to the clinic and you take an inventory of all the meds they're on, and might say, I'm on duloxetine, Cymbalta, or one of these, and you end their list, you say, oh, I'm also take CBD. What
I
would you tell them about that?
no. I mean, if a patient can come to me and say they take, and some of the patients in the study did get CBD and did think it helped them. We're talking average group level, yeah. So some of the patients also in the CBD group had an effect, and if they had an effect, it means it worked for them. But if it's a new patient, some people called me also, do you have the results yet? Because I'm wondering if I should buy it or not. And then I said, yes, I have the results, and probably not. I mean, because expensive for them also. It's very, very expensive. It's like more expensive than treatment with Ozempic. So they were asking me, is it worth doing? But I would never say to a patient that takes it and has a good effect, I would never say to stop, keep going if it's possible. It's not dangerous. There's no harms. We didn't have any bad side effects. It's only mild side effects. So
I think I might push back a little bit. Often people do things like this, especially in the world of fibromyalgia. And you pointed out a real important thing is the cost. And as I think clinicians to say what impact there's often in the functional medicine world, and I don't know how much you have that in Denmark, but it's often they'll say it's the N of one. It's your own personal test subject. So you can test all of an herb or a supplement and, oh, does it make you better? But when we look at randomized control, what I think it counters, like maybe the placebo made you better. People literally had nothing. They thought they had a placebo and they thought they did better too.
yeah,
Um, and when we look at recommendations, like when you look at what are recommendations, I'm guessing the recommendation is Hits originally said you had to write recommendations on this, right? Several years ago. And now what would the recommendations say in light of this
they
study?
will say to not use it, of course, as a result of the study.
Yeah.
This was disappointment to us because we really wanted to find something that works. And we wanted it to be on a recommendation so that it could be reimbursed, so that it wouldn't be expensive. This was what drove us to do the whole thing. So both myself and the rest of the research group were disappointed. And of course, there won't be a recommendation now in Denmark recommending this due to the results. But still, if somebody has an effect, they should definitely use it. That's what I have to say. It's individual because we have group level, and yeah, we had more people in the placebo group experiencing an effect, a relevant effect, a meaningful effect to them than in the other group. It's very strange. But they were also in the other group, those people.
Yeah. Which then makes you wonder, does it get better? And I think there is that positive connection and that hope that it can be better. And I'm sure that patients who get a chance to work with you can sense that you care about them and love them. And I'm sure the staff was hopeful. that this may be. And so I think there was an optimism in the air. I am just guessing that there might have been, you had the cap that there were too many people, then you could only fit so many in the study. And there were many who were probably disappointed on the sidelines that they didn't get a chance to participate.
For sure. Yes, that's true. We had to stop and we had the 200. But it was really rewarding. And now, soon, next week, actually, we are going to get everybody together and we're going to tell them about the results. May I have a lecture for them and they will have the ability to ask questions. And a lot of people signed up for that. So we're excited about meeting them all again. But yeah, it was maybe not so professional when doing a clinical trial. There was optimism in the air. This was what drove us. And yeah, it didn't work, unfortunately.
Yeah, and that can be some disappointment, but it's actually really important. And I'm so glad that you did this study, because a lot of clinicians get the question. A lot of that is marketing, often by non-medical people who are selling this in dispensaries, offering this as potentially a hope in the United States, because it is not, at least in the FDA approved, as sort of a supplement kind of thing. It's a separate category, so you can make statements about something that aren't as rigorous as yet when you have a prescription medicine like an Ozempic. You have very strict things on what it's covered for, what you can use it for, etc.
Yeah.
Before we wrap up, is there anything that we haven't talked about that you think is important for people living with fibromyalgia, or for clinicians caring for people with fibromyalgia, or for their loved ones for that matter?
Oh, yeah. There's so many things we can talk about. And I worked with this for so long and talked to so many patients. For a clinician, I have to say that when it comes to trying the drug, or for the person who wants to try it, we know it's safe. It's no harm in trying it, but it's also expensive, as I've been talking about before. And the cost has to be weighed up to the limited effects that we found. For the patients, what they need is they need to be seen by doctors or health professionals who believe that they are very, very disabled by this disease. It's very serious for them. They have very low functional ability. It's hard for them to hold a job and everything. So they need education. They need non-pharmacological interventions. They need to be diagnosed early, to not hang in the system and go through all kinds of other things that's unnecessary. It needs to be diagnosed so they know what they have. And then it's important to give them an intervention to help them prevent decline on their function and to keep the function that they have, maybe improve, so that they can have a full life. So I think we have to look away from pharmacological interventions and into what else can be done. We have showed actually that care and seeing the patient works. So I think for clinicians, this is also something to think about. And for the patients, it's all about finding that balance so that you can have a full and worthy life, even if you have the chronic pain every day.
Yeah, and that kind of echoes what this podcast is about, and what this YouTube channel is about, is to try to give education for people who may not have it. Clinic visits are short, but fibromyalgia and related syndromes are complex, and often the answers are hard to explain quickly compared to the simple biomedical model approach. But taking the time, and if this is the first time you've ever gotten a chance to watch this YouTube channel or podcast, just look at all of what I put together for the podcast and the YouTube channel, because I try to bring a very broad array of information, bringing expert clinicians that are bringing up-to-date information on things like fibromyalgia, chronic fatigue. I interview people who are living with this to help validate. Often when you're the only person going through this, it can feel like you're invalidated. Many people, their extended family has dismissed you as somebody who's a hypochondriac, who isn't real. But hopefully that's kind of been a mission of mine, to support people who are struggling. I often use the analogy of living with this can be like you're blindfolded, bound, and tortured by an unknown assailant without any recourse for relief. And education at least starts to take off the blindfold, and you can start to see, oh, this makes sense. Oh, I didn't know there was this connection between all of these other co-occurring things. And it's time. I have a physician's assistant that'll be likely working with me coming up in a couple months to help support. And she shadowed me. And I said, this is a lot of the patients I work with. I do both primary care, but a huge part of my practice is working with people who have chronic pain syndromes. It's kind of one of these, once you get known in the community as somebody who does this, then you see family members and friends and word of mouth and Facebook groups. And I end up seeing lots of people who have these struggles. And it's the hope to offer them, but yet not to give them, for many of this, you'll read a book about fibro and then at the end they say, oh, here's a supplement to try. Here's my special supplement. And as I like to say, this podcast and YouTube channel are supported by listeners, not by supplement companies, not by any of these things. It's just trying to offer that, taking the extra time out of my life to help support people and hope that, again, with these physicians assistants and doctors in training, they can have this understanding and learn and enjoy helping people get better.
Exactly.
I would just want to again thank you so much for you and your team. So you can share that at least one medical doctor in America who has, I think, the #1 podcast on fibromyalgia, humbly speaking, is seeing and checking out these important data studies, trying to bring up-to-date information for people who are listening, and for yourself and for your passion and for your team, and spending this time to connect finally through these different time zones.
Exactly. No, that was a pleasure. I'm happy that I was invited to tell you about the study.
Subscribe and leave your comments below. That way, others will be able to find this important information and clinical insights easier.